All right, today we're going to talk about the liver, and what you're going to find as we go through is you're going to hear a lot of repetition, and the more you hear about these things, the better they're going to connect into your mind. So when we talk about the liver, it's the largest organ in the body, and one would think that it's really easy to see, but I think when you're going to find out is when you get out there and start to scan, it can be quite a difficult organ to image. Everybody's body habitus is different. Most of the images that we show you are textbook images. And I would venture to say, in my experience, that accounts for less than 10% of the population out there. But it's nice to see that so you can register it in your head. This organ is about 1,500 grams. It's about 15 to 17 centimeters in length, depending on the literature. And it's most important when we say 15 to 17 centimeters in length, that's done at the midclavicular line. So that's going to be a line that runs mid-clavicle straight down. That's important because when we measure the liver, we want to correlate what the clinician is feeling when they do a clinical exam. And many times you'll find the easiest way to see the liver is going to be from a coronal approach off to the side of the body, because we can go through the ribs and we're not dealing with gas in the hepatic flexure of the colon or the transverse colon. But you're not doing the patient a service if you measure it in that particular line, because then there's no correlation to what the physician is seeing when they're asking you to rule out hepatomegaly. So from an anatomic perspective, the liver takes up the entire right hypochondrium, the greater part of the epigastrium, which is here in the center of the body, and the left lobe is part of the left hypochondriac region. The problem with that is that adjacent to the left lobe is going to be the stomach, and the stomach almost always contains air. And as you'll find when you do this, air is the enemy of ultrasound in a lot of respects. We can't see through it. All we get is a really bright interface and then a lot of dirty shadow behind it. The contour and shape of the liver, everybody knows what that looks like in the textbooks, but in real life, it varies tremendously depending on body habitus. So it lies inferior to the diaphragm. It's covered by the ribs, which means then that makes it a little bit more difficult for us to see things. We talk about using the curvilinear probe a lot because it has a nice big footprint. It gives us a big image that we can look at. But once you have to get off to the side and you start going through the ribs, that presents another set of problems, because then you get shadow of the ribs within that space because you have a curvilinear probe that has a footprint a couple of centimeters wide, and yet your intercostal spaces are much smaller. So it may help you to use a vector probe or a phased array probe, a sector type of transducer, so you can get in between the ribs and you minimize that rib shadow, because anytime you have a shadow, it's going to obscure structures behind it, and you're not going to be able to see that portion of it. So you have to move back and forth. The fundus is posterior lateral to the left lobe, so it sits behind it and sits a little bit more lateral. Everything runs all together, so you have to look at everything on your image, and you have to think about things three-dimensionally again. I can't say that enough. You have to understand it in 3 dimensions, because when you look at the image, you need to see everything that's on that image and put the pieces together. The duodenum is adjacent to the right lobe, for example. So it's part of the medial segment of the left lobe, so we have to understand the anatomy, and we use that duodenum and that C-loop to help us identify structures. The pancreas sits below the inferior left lobe, so when we scan transversely, you'll be able to see a piece of the pancreas, but you'll only see a little portion of it because our window is small. It's like looking at a loaf of bread. So unlike a CAT scan or an MRI where you get subsequent images and you see in one slice, you see the entire outline of the abdomen from anterior to posterior and right to left. When we do ultrasound, we're seeing things as with a flashlight, like CSI, for example. And only what's in that defined beam is what we see. Anything outside of that is obscured to us. So we angle that flashlight beam and we point all the way around to look at what we're seeing. The posterior border of the liver is an intimate connection with the right kidney, the IVC, and the aorta. So anytime that you're looking at the liver, you're going to see these structures either touching it or very, very close to it. And we'll use these structures to help us identify where we're at when we're looking at that particular piece of the liver. The diaphragm covers the entire superior border of the liver, and the liver is held in place by the falciform ligament. Now remember, the basic premise of ultrasound is the more dense the structure, the brighter it is. The less dense the structure, the darker it is. So fluid is going to be the least dense structure in the body that we see. That's going to be black. And we have varying degrees of gray as we move towards very bright. Your ligaments and your tendons are bright structures because they're extremely dense. So that helps us when we look at the overall picture of the liver, knowing the anatomy, as to what we're looking at based on the echogenicity of that particular structure. Most of the liver is covered by the peritoneum. There is a small area that is in direct contact with the diaphragm. That's called the bare area. That becomes important because that can be a portion of the liver where you can get processes, pathologic processes, that pass through the liver into the chest. Most times everything is contained within. So this is an image of the underside of the liver here. So what we're looking at is the falciform ligament. It's displayed as white because it's very, very dense. The ligament of Terry's number 2 goes through the falciform ligament. The porta hepatis is the term that we use for the area that goes right into the liver, comprised of the portal vein, the hepatic artery, and the bile duct. That's the portal triad. You have the gastric impression on the underside of the liver where the stomach is intimate contact with it. You have the renal fossa where the kidney is right up against the liver. And all of these, even though that looks like it may be a straight line with ultrasound image, and we'll see that as we go through a lot of the ultrasound images to reinforce what we're talking about from an anatomic perspective, you don't really see the concavity of where the liver and the kidney touch, but it's just a small depression. There's also a gallbladder depression, and we say that the gallbladder lives within that gallbladder fossa. But as you scan and you see a lot more patients, you'll find out there's a wide variability. Once again, when we talk about this, we describe it in a textbook fashion. This is where it's supposed to be. Anybody who's been inside the abdomen knows that there's a lot of variability. The liver is primarily divided into 2 lobes, the right lobe and the left lobe. The right lobe is the largest by about 6:1, and it's divided into the anterior and posterior aspects by the right hepatic vein. The left size varies tremendously. You can have a big left lobe, you can have a left lobe that's going to go all the way over and touch the spleen, you can have a tiny little one which is medial to the stomach and more midline in location. One thing I want to mention to everybody, we don't see it a whole lot anymore as we did in the past, but there's a projection called a Rydell's lobe. It was initially thought of that this was a cause of women wearing corsets all the time, and this little slip of the liver came down. Maybe that's why they saw it a lot in the past and they don't see it anymore. It still does occur more frequent in women. I haven't found a really good explanation in the literature for this, but it's a slender piece of liver tissue that extends down towards the pelvis. If you look at this coronal image here through a CT, you can see this is liver here. This is a contrasted CT, so we have the hepatic vasculature, which is displayed as bright white. All of this is liver. And instead of having this concavity here that moves back up to the left lobe, you can see this slip of liver that comes all the way down and just about touches the edge of the iliac wing here. We also have the caudate lobe. That's a small projection inferior. It lies on the posterior surface of the liver. It's separated from the left lobe by the ligamentum venosum, which is this white line here. Remember, anytime we talk about a ligament, we're going to be looking at something that's very bright. Ligamentum venosum is a remnant from fetal circulation. When we look at this image here and we talk about putting all the things together, just to reinforce what Lori was saying earlier, we have a big black tube here, and not knowing where we are in relationship to the body, this can be one of 2 structures. It can be the aorta or it can be the IVC. So when we think anatomically, we want to put things together as we scan, we think about the 3-dimensional anatomy and what each individual structure does. So I look at this image here and I can say that this is an IVC, and there's a couple of reasons why. One, the IVC always touches the liver parenchyma. The aorta doesn't. The space between the anterior wall of the aorta and the posterior wall of the left lobe of the liver, at the line in the body of the aorta, that space there is where the GE junction occurs and the esophagus comes through the diaphragm. So the aorta will never touch the liver. It'll be close to it, but never actually touch the parenchyma. The IVC has a hammocking effect the aorta was a straight structure. If you recall, Lori put an image up there and she talked about the angle of incination to the aorta. And the aorta came up at an angle. And she recommended that you change that so you become perpendicular to it. So the aorta is always a straight structure. Anytime that you approach imaging in the right upper quadrant, so many things are intimate with everything else. We need to use these little clues to help us determine what we're actually looking at in that little flashlight beam area. So the caudate becomes important, and we'll talk about this a lot more when I talk about pathology. And it's important because it gets its blood from a different source than what the rest of the liver does. And so it communicates directly with the IVC. So what happens is, because it's functionally different, if you have processes that occur in the liver, hepatitis, cirrhosis, things like that, the caudate lobe can be spared. Because remember, everything that comes in typically from the rest of the body comes in through the portal vein. It doesn't necessarily go to the caudate lobe. We need to talk about segmental anatomy just briefly. There's 4 segments, there's 3 lobes, the right side and anterior, and the left is medial and lateral. We also have the caudate lobe. If you work with surgery closely, they're going to want to look at the segments from the surgical segment portion rather than the radiology segment portion. We typically in radiology look at the right lobe, the left lobe, anterior, posterior, medial, lateral. Surgery looks at it from how they are going to dissect things. So when we look at an ultrasound image, this is a transverse image, subxiphoid, angling up towards the heart. And from a radiologic perspective, we use the hepatic veins to divide the liver into our different segments. The IVC sits back here. This bright line here is the diaphragm. Remember, the diaphragm is a fibrous structure, so that's going to be dense, and it's going to show up brighter than the surrounding tissues. The question was, why does the diaphragm look like it's at the bottom of the image here instead of at the top where you would expect it to see, because the diaphragm lays on top of the liver or superior to the liver? Remember when we were talking about pointing a flashlight and the way that you look at things, the first thing that you pass through is always going to be at the top of your screen. So when you pass through here, you're going to see the liver. If you come around to the back and use your transducer, you're going to pass through the right lobe of the liver. Think, for example, that when I want to look at the right kidney, I can come in anteriorly and I could go through the anterior right lobe of the liver, the porta hepatis, the posterior right lobe of the liver, and then look at the kidney, which would be at the bottom of my screen. Okay? If I took my transducer and I went all the way around to the back and I looked through the psoas muscle, that would put the psoas muscle at the very top of my screen and the kidney right underneath it. So in this particular view here, we have the transducer sitting on top of the body here anteriorly, and we're pointing the flashlight beam up towards the patient's shoulders. So we point the beam from on the skin surface through the liver and up towards the chest. So for me to stand up here, instead of going straight back, we're going to take that beam, we're going to tip it up towards the chest. So now, in relationship to where I'm touching my transducer on the skin, it makes the diaphragm look at the bottom of the image. Okay? So when we look at this, we use the hepatic vasculature to help us determine our demarcation from a radiologic perspective. This is IVC here. The heart is going to be up here because we're pointing up. This is the left hepatic vein, the middle hepatic vein, and the right hepatic vein. The left and middle come off the same trunk. Now, I mention that because it can be difficult in a lot of patients to see this, and depending on what the echogenicity of the liver is and what pathologic process they have, it's not easy to see that demarcation. So we can use that being the same trunk to help us identify. Or for example, if we have a Budd-Chiari syndrome where the hepatic veins are very, very small and we can't see them, it helps us to delineate that. So the left hepatic vein separates the left lateral portion of the liver and the left medial. The middle hepatic vein separates the left lobe from the right lobe. The right hepatic vein separates the posterior aspect of the liver and the anterior aspect of the liver. Sometimes it's difficult to pick out this vasculature and know if you're looking at a hepatic vein or a portal vein. There's a couple easy ways to make that determination. The portal vein will have a white ring around it. The hepatic vein does not. And the portal vasculature has that white ring because the capsule of the liver, which we'll talk about in a little bit, is contiguous with the porta hepatis and the portal triad as it invaginates into the liver. And that capsule, which is fibrous, goes along with it. So if you see one image, like here for example, see that white ring around there? That's a portal vein. See how the black area of the hepatic veins interact with the liver and there's no white interface? That's the hepatic system. Another cool way to do this, and another little trick, is if you can identify the bifurcation. If the V of the bifurcation points towards the patient's head, it's going to be a hepatic vein. If the V points towards the patient's feet, it's going to be a portal vein. If you think about that, the portal vein comes in from underneath the liver and it bifurcates into its smaller channels pointing towards the head. So the V points towards the feet. The hepatic system comes in from the top and the V points towards the patient's head. And we'll talk a little bit about that when I show some of the vascular images. So from a surgical perspective, you have the caudate lobe is 1, 2 and 3 is left superior and left anterior, 4A, 4B, 5, 6, 7, and 8. And that's Kuno's description of this. And I'm not going to get into each one. I could spend 10 minutes for each thing, but suffice it to know that there's 2 different ways of looking at the liver segmentation depending on who you're dealing with. Many radiologists now are starting to include that when they do CT scanning. It hasn't morphed over into the ultrasound world yet, but you may see it as you go through your practice and you have longevity doing this imaging. So fissures and ligaments, we have Glissen's capsule, which covers the entire liver. It's that thin fibrous tissue that you see if you've ever seen gross anatomy of the liver. We have the main lobar fissure, the falciform ligament, the ligamentum of teres, and the ligamentum of venosum. Those 5 things are going to be the bright areas that you see within the liver when we talk about fibrous structures. Glissen's capsule is thin connective tissue. It goes completely around the liver. The main lobar fissure is the boundary between the right and left lobes, which is here. It's the echogenic, and we use that to find the gallbladder. It connects the portal vein to the gallbladder. So when we look at one view, we'll see the portal vein. We follow that main lobar fissure out, and then that's one of the tricks to how we find the gallbladder. And it's in a general area running from the xiphoid to the right shoulder. The falciform ligament contains the ligament of teres. This can be very, very bright, and it can be very, very round and transverse. So you have to be careful not to mistake it for a mass, because we do have echogenic masses within the liver, and we'll talk about that when we talk about pathology. Because it's fibrous, again, it's going to be very bright. It divides the medial and lateral segments of the left lobe of the liver. So when we look transversely here, once again, you can tell the portal veins because they have that white ring around them. You can tell a hepatic vein because it does not. And you can see this bright echogenic structure. As you scan through, it's going to separate the left lobe of the liver from the right lobe of the liver. And you can follow this all the way straight down. It's going to vary from person to person. It can be kind of big. It can be a thin line. But it will always be there, and usually it's dense enough that it causes a shadow behind it. The ligamentum venosum separates the left from the caudate lobe. So here once again we have a longitudinal image of the liver. This is the patient's head, this is the patient's feet. And we have what structure here? It touches the liver, and it has a hammock effect to it. And then you can see this bright little line right here. This is left lobe here, and this is caudate lobe here. The portal venous system is a dual supply. The hepatic artery is oxygen rich. The portal vein is nutrient rich. It has a little bit of oxygen with it, but not near the concentration as what the hepatic artery does. The portal system is made up of the main portal vein, where it comes into the liver. And then just as you enter the liver, there's a split that goes over and becomes the left portal vein. And then the portal vein continues into the liver a little bit more as the right portal. And then that further splits into the anterior and posterior segments of the right lobe. The porta hepatis, we just talked about a little bit, that contains 3 structures. It contains your portal system, the portal vein, it contains your hepatic artery, and it contains the biliary tree. So all three of those have a white ring around them. Now, when we talk about that white ring, we don't see the intrahepatic biliary tree unless it's dilated, so we're typically not going to see that white ring. We do see the portal vein all the way through. You can see the hepatic artery in most patients, although some patients it's a little bit smaller. And that's what we use color Doppler for, to help us identify these structures as we look at them. So here you have the portal vein coming in, the hepatic artery, and the bile duct. That's your portal triad. It comes in from underneath the liver and courses towards the patient's right shoulder in orientation. And from an ultrasound perspective, here we have left lobe of the liver. Here's some of the right lobe of the liver. We have IVC. We have common bile duct, and a little bit of the portal vein. The common hepatic artery comes off the celiac trunk. The two anterior branches are the SMA, which comes off and then bends and goes down towards the patient's feet. The celiac axis comes straight up for the most part, may angle a little bit more towards the head, and then as it comes off the aorta, it splits transversely into the hepatic artery and the splenic artery. The hepatic artery comes over, there's a branch that becomes the gastroduodenal artery, and the hepatic artery is the largest and courses into the liver with the portal triad. So here's an example transversely, and there's a huge amount of variability. If you look at Netter images, it's going to come straight up, and it's going to have this beautiful gull wing appearance. In reality, never happens. But knowing the anatomy, transversely, this is shadow from the anterior surface of one of the vertebral bodies. It's curved. That's what we would expect to see from that bone. And it has a well-circumscribed shadow behind it. Here we have aorta. We have IVC. And you can see this branch come up here. Remember, we're transversely. It splits into the splenic artery, which goes over, and we'll talk a lot more about that when we talk about pancreas. And then the left part of the branch becomes the hepatic artery, and this will course over, and that will go into the liver. So here we have main portal vein, IVC. So we're at an oblique view. We have the lateral edge of the gallbladder in the gallbladder fossa. And then we have hepatic artery and bile duct. Many times it's almost impossible to tell these apart without looking at Doppler. There's a general rule of thumb when you look transversely. I'll show you one of these. We have what's called the Mickey Mouse sign. But that's a generalization. It's just a rule of thumb. You need to put Doppler on and you need to look at these because they're so close in diameter and there's so much variability. You can have a slightly larger hepatic artery, you can have a slightly larger common bile duct. You can't mistake one for the other. Here's just a schematic of the celiac axis coming off. Here we have splenic vein, here we have hepatic artery, gastroduodenal artery comes off, hepatic artery comes off and goes right into the liver with the portal triad. So the main portal vein, like I said, there's a lot of overlap when we do these lectures. The main portal vein is the junction of the splenic vein and the SMV. So you have the superior mesenteric vein coming up from underneath, you have the splenic vein coming over from the spleen, it follows the outline of the pancreas, they come together and then they become the main portal vein. Small intestine absorbs all the products of digestion, that's why this is nutrient rich as it goes into the liver. And then all of these go up and they go ahead into the liver, they get filtered out, they get taken out, and they do from a physiologic standpoint. Here's main portal vein, you'll see a lot of these. IVC, diaphragm, which remember is going to be echogenic. We have a hepatic vein here. We have the lateral edge of the gallbladder. And here we have a couple of tubes on top of these. So once again, there's no way to tell what this is unless we interrogate it further. Here's a CT exam. You have the splenic vein going over to the spleen. You have the main portal vein coming in. This is actually fairly far into the liver, so we're looking at the anterior segment of the right portal vein and the posterior segment of the right portal vein. The left portal vein is off the screen here. Here we have kidneys, and we have vertebral body, stomach. But sometimes it's nice to see this big overall picture so you can get a good global view of what you're looking at. The main portal vein divides into the right and left. So if we look at the schematic up here, we have the right portal vein, we have the left portal vein, As they come in here, this is main portal vein, it turns into the right portal vein. We have the anterior segment and we have the posterior segment. It's important to remember how these go from an anatomic perspective when we start talking about Doppler. For example, if you get into that realm of doing ultrasound, because remember Doppler, specifically color Doppler, your color is based on direction of flow. So if you have the transducer here on top of the body, the anterior segment of the right portal vein is going to be coming towards you, so it's going to be displayed as red. The posterior segment of the right portal vein is going to be displayed as blue because it's going away from where the transducer is on the body. When I talked earlier about putting all these pieces of the puzzle together based on where you're pointing that flashlight beam, if you take the transducer, for example, and then you come around to the lateral edge, now that right portal vein, that posterior segment, is coming towards the transducer. Everybody with me on that? So now that's going to display that as red, and it's going to display the anterior segment as blue because that's going away. And it's all based on the orientation of where you put the transducer on the body. The right portal vein is larger than the left portal vein is, as a general rule of thumb. We talked about the anterior and posterior segment. The lateral portion goes up through the lateral segment of the left lobe. There's 3 hepatic veins, the right, the middle, the left. We talked about those. Here's that same image we showed a little bit earlier minus some of the annotation. So the right's going to be the largest because it makes sense. That's draining a larger portion of the tissue, so it's going to be larger in size to take that volume. The left is smaller because there's a smaller left lobe over here, and it's the volume from that area that's draining back to the heart. We talked about the left and the middle having the same trunk, and the right comes off the IVC on its own. They drain into the IVC superiorly, so right up at the level of the diaphragm. And then they branch out. They're larger where they dump into the IVC, and they're smaller as they go out into the liver. Conversely, the portal vein is going to be larger where it comes into the liver from below, but it has the same appearances on top. They're larger on the outside, and then as they come in, they get smaller. In order to see all of the hepatic veins in one image, you have to scan transversely. Because if we back up here, if we're doing a longitudinal view, this is transverse. So our fan is coming out to see all 3. If we're longitudinal, we're only taking one slice. So we're only going to see one at a time. We'll be coming through this one here, and then we move the transducer over and we come through this one here, so on and so forth, in that loaf of bread. Some other examples of the portal vein versus the hepatic veins. Once again, the portal veins have that white ring around them. Now remember, when I give you this information, I'm talking about normal. So I'm assuming that the liver parenchyma is going to be normal when I say that these have a white ring around them. That becomes important when we talk about pathology, because when you have different pathologies, for example, if you have a fatty liver and you have to adjust your TGCs, like Lori was saying earlier, a fatty liver means the liver is going to be brighter. So as the liver parenchyma starts to get brighter, what's going to happen is it potentially could reach that threshold where it's as bright or it's as dense as what that little white ring is from Glisson's capsule around the portal vein, so it may be harder to see. When we talk about pathologies, one of the things we talk about is we talk about the loss of the periportal echoes, and that's what that means. The liver gets bright enough that we don't see this interface very well. So hepatic veins, no white ring, and one could say, well, that looks white along here. Well, think about the basic physics of ultrasound. Anytime you hit something perpendicular, you get the best reflection, right? So if you hit a wall of a blood vessel, whether it has fibrous tissue around it or not, it's going to have the highest degree of reflectivity. And if you look at the angle of this beam here, the way this beam is coming out, that makes that exactly perpendicular to this piece of the wall. If you shift your transducer off to the side, you will lose that echogenicity. And that's a good thing to keep in mind. If you're trying to figure out if something is echogenic or not, change your angle of inclination, move the transducer around, because it's going to go away. Those of you that do MSK, we talk about anisotropy, where the parallel fibers of your tendons, when you hit it 90 degrees, it looks very, very bright. As soon as you take the transducer and you tip off of it, you can make that look hypoechoic, because it changes the angle of incidence, so therefore it changes the physics of the way the sound beam interacts with the tissue. Portal veins mostly on this side, and you can see they all have that white ring. Another example of the hepatic veins that we keep looking at here, you can use that V. Here you can see the V of the bifurcation is pointing towards the patient's head because we know that we're scanning from here and angling up to the patient's head. And then this is just an example on how all of these, you have them larger on the bottom here. As they split, they start to get smaller and smaller from underneath, and you can see the V of all of these branches from the portal system point towards the patient's feet. Conversely, all of the V's for the bifurcations of the hepatic system point towards the patient's head. So why do we do liver ultrasound? We do it in patients who complain of right upper quadrant pain. Mostly we're going to be looking for the gallbladder, but you can't discount everything else that you see in the screen. If you take one thing away from today's lecture, take this away. When you're doing an exam looking for something, you cannot discount. You have to evaluate everything that's in your frame of reference. You don't want to be looking at the gallbladder because I'm looking at the gallbladder and not see a 1 centimeter metastatic lesion in the liver because you're focused on the gallbladder. We do liver ultrasound or right upper quadrant ultrasound for abnormal labs. Your LFTs play a huge part in looking at the liver for different pathologies and different things that occur. We do right upper quadrant ultrasound or liver ultrasound in the case of trauma because we want to look and see, is it ruptured? Is there any free fluid? What does the architecture of the liver look like? Biopsies for hepatologists or radiologists if you're biopsying a particular lesion. And we do right upper quadrant liver ultrasounds for the evaluation of ascites. So when you look at the liver, there's a couple of things you want to look at. You want to look at the size of it. We talked about the rough size of 15 to 17 centimeters. You want to look at the capsular contour, or what does the edge of the liver look like? Is it smooth, which is what we would expect it to be? Is it coarse? People who undergo cirrhosis and hepatitis, it gets to a point where it gets fibrotic and the liver becomes nodular. So you don't have that nice, smooth liver capsule. It looks bumpy. What does the echogenicity look like? Is it too bright? Is it too dark? Hepatitis makes it dark. Cirrhosis makes it bright. Fatty infiltration makes it bright. So it's really key to understand what normals look like, because when you look at what you can do with the machine, just turn that gain up and make it bright, or turn the gain down and make it look dark. Does the appearance of it mean that you did it from a technical perspective, or does it look that way from a physiologic, pathologic perspective? You do want to look at the vascularity if you're doing it. Do the veins look too big? Can you see the walls of the portal system well? Maybe put on Doppler, look for the direction of flow. A cirrhotic liver, you're going to want to look at the portal vein, make sure there's not a hepatofugal flow. We want to look at the biliary tree in most cases because we associate that with gallbladder disease and obstruction. And we want to look at the liver for masses or collections. How do we do it? Well, if you look at the nomenclature of things, we do it longitudinal and transverse. But that implies that we only do longitudinal views and we only do transverse views. In reality, there's a million degrees of orientation when we talk about it. True longitudinal is going to be this way to the whole body. But you know, we're looking at the liver longitudinally, but we're coming in from a coronal approach. Or we're looking at the liver longitudinally when we're coming in from a posterolateral approach. And the same with transverse. A true transverse to the body is putting the transducer and never moving it. But when you get to the ribs, you're going to have some bit of obliquity to it. You're going to be moving up and down the ribs. You're going to change that, so there's a lot of variability. That's why it's important to understand the anatomy in 3 dimensions and take that flashlight into consideration. Where am I touching the body and what am I pointing to? This is what we call a pinch grip. This is what you should not be doing with ultrasound. It can cause musculoskeletal problems, but for the sake of producing a nice image to show you where the probe is, you'll see the person here using a pinch grip. So we have the transducer. We're longitudinal to the body. We're underneath the ribs. So when you scan the liver, that's the best way to start. Underneath the ribs, you can have the patient take in a deep breath. When they take in a deep breath, they fill their lungs, the diaphragm moves down, it pushes the liver down. If we can't see it underneath the ribs or subcostally, then we're going to come off to the side and do coronal imaging through the ribs. So we're looking at the liver longitudinally. We have the liver here, diaphragm, hepatic vein, portal vein. We have kidney. Same image down here, liver, kidney. So remember, we're pointing the beam through the liver towards the back of the body and a little bit towards the patient's head. Here's some of the obliquity that I was talking about. This isn't a true transverse, but in this particular person here, we're seeing all the hepatic veins, but from a slightly oblique kind of view. So that's what I was saying earlier, is there's a lot of variability in the liver based on body habitus. That's the beauty of ultrasound. Nothing is ever the same. Transversely, again, under the ribs, pushing a little bit, having the patient taking a deep breath, we're seeing transverse liver. IVC, we're imaging up towards the diaphragm, so we're pointing up towards the diaphragm. Portal system for that white ring. Hepatic system without the white ring. Scan transversely. Just underneath the subxiphoid process is your best view to find the left lobe. I can guarantee you you're not seeing the entire abdomen in the vast majority of patients. This is a little pediatric patient. So we can see both kidneys lying on either side of the spine. We see the pancreas. We can see the aorta, the SMA, the IVC, portal splenic confluence, and all of the liver. So we'll start transversely here. We angle up towards the patient's head so we can see the hepatic veins come off. Now while the transducer is in that spot, and you'll get a lot of time to do this when you do your hands-on scanning. Once you find a nice window with ultrasound, a window is defined as something that allows you to get the ultrasound beam to the structure that you want to see. And that can be a whole host of different things. It can be a burr hole in the OR if you're looking for the brain. It can be the anterior fontanelle in a neonate looking for the brain. When I started doing this, CT was in its infancy, so we used to look at the tail of the pancreas. So we would have a patient fill their stomach with water and then have them lie on their left side. So the air became gravity dependent up towards the antrum of the stomach. It would leave the stomach, go into the duodenum, and then we would lie them on their back and we would scan through the stomach as a fluid-filled structure to look at the tail of the pancreas. We used to fill women's bladders to push the bowel out of the way, tip the uterus back, and scan and use that as a window. So anytime you find a good window, you want to stay there and you want to angle the transducer or rotate the transducer rather than moving the transducer. So subxiphoid is a good window to see a lot. We put the transducer subxiphoid, we angle up to the head, and we get the hepatic veins. Then we keep it there and we just angle inferior a little bit more. Now we start to come in anatomically, we're coming into the left portal vein and the umbilical portion of the left portal vein. And then we angle down a little bit farther and we're coming into the left portal vein. We're still seeing the IVC in all these views because remember, that's going to stay constant. All we're doing is we're taking the transducer and we're tipping it down towards the patient's feet. And we'll do the same thing when we do longitudinal. So now we're below the superior and anterior portion of the liver and we're starting to come into the posterior portion of the right lobe. We still see the IVC. And all that is keeping the transducer in one spot and tipping it towards the patient's feet. You'll find out when we have to look through the ribs, you can get into rib space and you angle up underneath the superior rib, image down below the inferior rib, and then you reach a point where you can't see anything anymore, the rib's in the way, so you got to slide the probe over the top of the ribs and do the same thing. Angle up underneath that rib, angle down. So you fan that beam in between the rib space. If everybody can see that. We want to look at the size. We talked about that, the contour, the parenchymal echogenicity. So longitudinally, we're going to look at the left lobe. We're going to include the aorta. We're going to look at the caudate lobe. We're going to look at the right lobe, and we're going to include the gallbladder in the right lobe. We're going to look at the posterior right lobe, and then we're going to come out laterally. One of the hardest things that you're going to find to see is when you're scanning, it's very difficult to see the dome of the liver, the right lobe up near the diaphragm. It's tough because it's farther away from the probe where we can get it. We usually have to go through the ribs to see it. The reason why I say this is when we look at any organ, you have to see it in its entirety. So you can't clear any organ unless you see everything, and that's an area that gets missed an awful lot. So here's left lobe of the liver. It shows you about where we're looking at anatomically, where the transducer image is going to be, because remember, we only see a small piece, that one slice of the bread. And here we're looking at left lobe of the liver, heart's up here. We have Glisson's capsule, which is echogenic. We have a piece of the antrum of the stomach, as you can see here, we see part of the pancreas. We see the esophagus as it's coming through the diaphragm. Then we come over just a little bit farther. We're still staying in a true longitudinal. For the sake of the images and for the sake of telling you this, these are perfectly true longitudinal to the body. Remember, in reality, we're never true longitudinal. We have to have some type of obliquity, but it's easier to explain this way. So we're still longitudinal. This is still left lobe. We have aorta here. We have the SMA coming off. We have the celiac axis coming off. Here's the esophagus as it comes through the diaphragm, because remember, the anterior wall of the aorta never touches the liver. We can see a bunch of portal veins here. Then we come over a little bit farther. We see the IVC. It hammocks. We see the ligamentum venosum, which means this is what? Caudate lobe. And then we have left lobe of the liver here. Come over a little bit farther. We see right lobe of the liver. We see a little bit of the IVC. We see a little bit of one of the hepatic veins dumping in. We have main portal vein, ligamentum of teres possibly. But you notice how the transducer here is now changing. So we're not following a true longitudinal image all the way across. And the reason for that is, in the middle, you don't have a lot of gas. Once you start to get over to the side here, you start to get into the hepatic flexure, the beginning of the transverse flexure, and the ascending part of the colon. So there's a lot of gas. So if we have a window here where we can tip the transducer off to the side to help us image this structure. If we slide the transducer over, we're going to start to run into bowel. We come over a little bit farther. We may have to come intercostally now. So we're seeing the dome of the diaphragm, liver parenchyma, Glisson's capsule. Is this a hepatic vein or a portal vein? The V is going towards the patient's head, and there's no white ring around it. Hepatic vein. Here we have kidney. So this is the patient's feet, always in longitudinal, and we have a little bit of the psoas muscle here. We can see where we're scanning, and if we look at this cadaver image here, we can see liver. We can see the diaphragm, which is what we see here. We see right kidney in this particular view here, and a little bit of the psoas muscle behind it. So we've run out of space. There's too much gas here, so now we need to move intercostally. And we can get the same view intercostally, but we changed our orientation a little bit. So now we're seeing less of the upper piece of the liver here, because the liver is going to be up here, and we're seeing more of the kidney down here. Transverse protocol, left lobe hepatic veins. Then you slide down to increase the portal vein. See the left portal, the caudate, the right lobe with the hepatic veins, the right portal vein. So we're starting up high, and we're just coming down through, slicing through that loaf of bread. Subxiphoid view. So we're in this orientation here to see the left lobe, but we're coming in transversely, heart, IVC, and hepatic veins. As you angle up, you would see these come together. As you angle down, they come apart. Come down a little bit farther, we see the left portal vein, the umbilical portion. All this is left lobe, IVC. Here we see the caudate lobe. Remember that drains directly into the IVC. It's separated by the ligamentum venosum, showing you the orientation of the probe. So most of these were still tipping up towards the patient head a little bit. Believe me, this gets a lot easier when you get your hand on a transducer and we have a model. Now we're angling over towards the patient's right side, because remember, we're limited to that bread view. So when we talk about the bread longitudinally, we're talking about an individual slice. We turn it, we're still seeing slices. So if I'm angling over to the left lobe, everything that I see in my fan of the right lobe is going to be disappeared. It's out of that view. So now we have to take the transducer, we have to shift it over to that side, see the right lobe. Now we don't see the left lobe. So we're still seeing a portion of the left lobe here, but notice how we lose everything that's over here, because we can't see everything. We have to point that flashlight. So now we're starting with the right side here. Come down a little bit farther, so we see the main portal vein, the right portal vein here, the posterior segment, the anterior segment. And you can see all this dirty shadowing here. All this is from gas in the hepatic flexure. Coming down even farther, we have gallbladder, IVC, and we're starting to see right kidney in a transverse view. So now we're pretty far down. All this is going to be obscured with gas. Most times you're going to have to come off to the side and image this from a coronal perspective. That's what this person's doing here. They couldn't get anything up here anymore, so they have to swing their transducer down around the side. Now look at our viewpoint is we're seeing a much smaller area. We're just seeing the posterior, inferior aspect of the right lobe of the liver and transverse right kidney. I won't go into LFTs a whole lot, just so you know this is in the slide. These are your different lab values. Different lab values correlate to a different process when we talk about pathology, and I'll get into those a little bit more in that lecture there. But I mention it in here because this is a reason why we do ultrasounds a lot, is somebody comes in and they say they have increased LFTs and I want to look at the liver. When we talk about pathology, it's going to be important for you to understand what liver enzyme goes with what, because I'm going to be thinking something in my head. If somebody has an increased ALT, I'm going to be thinking something different that I'm looking for if they have increased bilirubin, and that helps us pinpoint our exam. AST is present in tissue with a high metabolic rate, so that means death or injury to cells. I'll go through these pretty quick. ALT, if that's elevated, you're talking about cirrhosis, maybe metastatic disease. Pancreatitis can affect your ALT. Hepatitis can affect it as well. So a lot of your itises or inflammations affect LDT. LDH is cellular injury as well, but you have LDH in kidneys, you have LDH in your brain, so it's a little bit less specific to what we're looking for in the liver. ALK-Phos, the same thing. That can be indicative of an obstruction. That goes along with bilirubin sometimes, can be cirrhotic. Bili is a breakdown of red blood cells. So one of the primary functions of the liver is to convert bile pigments, and then it gets secreted as bile, and then it fills up your gallbladder, and that's in a gallbladder lecture as we go through this. But there's a couple of different ways that your bilirubin can be changed. You can have too many RBCs which are just being destroyed, and that's one set of parameters. You can have just malfunction of the liver cells, and then you look at the other liver enzymes as well to see, is this a liver process, or can it be an obstruction? So those are kind of the three things that when somebody has an increased bili, we're going to be looking for these processes. When we talk about bili, there's direct and indirect. Indirect is unconjugated, which means it's not water soluble. So it hasn't gotten to the liver yet. So that's typically going to be an increased red blood cell destruction with big hematomas, and that hematoma starting to lyse and it's starting to undergo necrosis and be reabsorbed, or your anemias. So you can see if I have an increased, not only just an increased bilirubin, but I want to know, is the indirect increased or is it the direct increased? Because I'm going to be looking for different things. So direct, that's going to be a biliary obstruction. That's something that's happening inside the liver. So what I'm saying is it doesn't help you just to say there's increased bilirubin. You want to tailor your exam better, so it would be nice to know, is it indirect or direct? They do a ratio for the total bilirubin of the percent of unconjugated versus conjugated.